welcome to this episode of Community Connections, airing right here on OROMIA11. Today's guests are two very important individuals from the HueMan Partnership. We are talking about healthcare, we are talking about the opioid crisis across this country, and then we're going to talk to you about some resources and some connections to better your overall health. It's going to be a wonderful episode you won't want to miss. I'm so excited to have Rhonda Marie Chacolas Hassan here on the program and Clarence Jones. You both are here representing the HueMan Partnership. Welcome to the program.
Thank you. Thank you for inviting us.
Thank you for having us.
Now we're going to talk about the work you guys are doing at the HueMan Partnership. We're going to talk about healthcare in the community right now and what you guys are hearing with the people that you are working not only in partnership with, but also from the community standpoint, and then hopefully give people some resources on how to connect with you all further. Now, for people that are unfamiliar, Clarence, can you talk to us about the history of the HueMan Partnership?
The HueMan Partnership has really been around in various ways for more than 20 years. We were involved in a federally qualified health center. Then we became independent. So for the last 24, 25 years, we have been working in community. And what HueMan actually is a coalition of collaborators working together on public health issues that the community identifies as important. So what makes us different is that we are always looking to engage people in authentic conversations, relationships, to talk about what's really going on. And then we are connecting with the governmental officials, we connect with the researchers, we connect with data analysts and give them information so that they can have a more effective communication with whatever issues that they're facing with. And so we have really enjoyed that. I mean, there was one time where we were doing like 200 health events every year. But again, we're collaborators. So our whole goal has always been to promote the people that we work with because you do things that we cannot do. You reach populations that we don't reach, you know. We can reach them, but you are much more effective at it. And so our goal is to support you as you do the work. So that's what we do.
Now, you, Rhonda, are here in the capacity of working from a pharmacy standpoint. You are the president of the board of pharmacy, correct?
I am, and so one of the things that I have to do is I do have a lot of affiliation, and it's really important that I make sure that I'm not speaking in my governmental official capacity as my role as an instructor with the University of Minnesota or in any other pharmacies that I'm employed with or working. So I'm here representing myself and some of the work that I've done with HueMan, so it's important for me to say that.
I understand and appreciate the distinction. When I refer to that, I just want to kind of get an understanding on the work that you're doing with HueMan Partnership and what that looks like from the lens in which you're able to view helping people in this way and trying to find people that are interested in collaborating with you all.
Absolutely, great question. So the other thing is I also, in addition to having a doctor of pharmacy, I have a master's of public health. I have done analytics, so it's really about connecting that information in any healthcare sector and kind of using data to inform things. One of the biggest projects that I've been working with HueMan is with the city of Minneapolis and looking at how they combat the opioid epidemic and substance use disorders. And so one of the main products that they are using is Brixadi, which is a treatment and not just the Narcan or naloxone. So that's some of the things that I do. Initially, I started out like helping people review their medicines, helping people maybe try to navigate health resources. But again, when we start looking at impact, we want to empower our people that we collaborate with, as well as looking at how we can get in certain rooms that we typically haven't always been able to be in.
Your work with HueMan is under the role of community health strategist?
Yes.
Correct. And
yes.
so when you're looking at the ways in which medicine and pharmaceuticals are changing for the community, what are some of the concerns or some of the points of opportunity that you feel like it's important for HueMan as well as community partners that may be interested in working with you guys need to start looking at more?
I think that's a fabulous question. I think one thing we've traditionally underappreciated is the amount of data that's out there. So there's data out there that's literally by zip code that can tell you how many people have diabetes pretty much, or how many people have hypertension or mental health conditions. And so we also use medication as a mainstay of treatment here in the United States. And so people a lot of times don't understand that pipeline. How do I go from my doctor's office to accessing my medication? And so that's one thing that I try to help people do is, one, when you get a medication, is really important for you to communicate with your provider how you feel about it. I know there's some people, for example, who have high blood pressure and they're prescribed a class of medicines called ACE inhibitors. That particular type of medicine, an example is lisinopril. I know people who've had family members who have had angioedema, and that is when your lips and your tongue and your throat and all of that swell. It's very, very traumatic for people to see, and for people who've seen that, they're like, most assuredly, I don't want to take that type of medicine. It is used to help protect your kidneys, but people may not feel comfortable telling their doctor that, so there's other things that can be used. The other thing is our healthcare system is very complex. So we have the doctor's office, the preferred pharmacy networks, and then we have the thing that's called a formulary when your healthcare insurance provider tells you what medications they prefer for you to take. As you're listening to me, even talking to you, one thing that I really try to do is break it down in plain language and giving people things that they can use and saying, what is a formulary? What is a preferred pharmacy? And so that's some of the things that I have done. And then really saying, okay, providers like myself typically look at how often do you take your medicine, which is called adherence. Adherence, actually, for a lot of health plans, has some incentives for providers for you to take that. But what are those barriers to adherence? Like, is it how you feel? Is it that you can't access a pharmacy? Is it that you can't afford a medication? And it's really just what I try to do is look at all of those variables and realize that, yes, we have guidelines, but we have those individual needs that need to be met as well.
I think that's so helpful because we often hear about a medication, we'll say on the TV, and then they'll tell you all the side effects or something, and then they'll say, reach out to your doctor about taking this. And by the time it goes off, I don't know about either one of you, but I start to think whatever I'm dealing with is not that bad compared to the onslaught of things that they will tell you you may incur in taking this. And I think it's comforting to have someone that reflects our community talking to you in layman's terms about what your options are so that you can make the best decision for yourself going forward.
I just like to add with those ads. So we are one of 2 countries in the world where pharmaceutical companies are allowed to advertise. It's called direct to consumer advertising. So it's us, and I believe it's New Zealand. You will never go to England, you won't go to France, you won't go to anywhere else in the world where you see those commercials. And one thing that is really kind of scary about those commercials is everything that they've seen in clinical trials or after people have taken that medication is why they have to report that big, big list that can be very, very scary. So just kind of let people know that if you're traveling, don't expect to see those, but also just know those side effects are things that they are required to report to everybody.
I appreciate the distinction. Clarence, you were just about to add something, I believe, before.
Well, I was gonna say, you know, Dr. Rhonda is really a great treasure for us at HueMan. She was born in North Minneapolis. She went to school in North Minneapolis. She lived in North Minneapolis. And so when we get out into the community and we start talking about collaboration and coalitions and things like that, it's good for people to see people that can share their experiences and that there is a commonality that's there. I mean, one of the things that, you know, and I talk about us being a coalition of collaborators, one of the things that we look for in our work is that we have authentic relationships. You know, we're very, very clear about if we're going to work with you, we're going to tell you the truth. We want you to tell us the truth, you know, because we can't afford to keep playing with our people's lives. And so part of the things that we do, it is hard. I mean, some of the things we have to say, it is hard, but you have to give people enough information for them to make an informed decision. So those people that are looking at those ads, they have to make an informed decision about whether or not they're going to take it. So that's what I would say.
Now at HueMan, you guys use a four-pronged approach to look at health. You are looking at medical health, mental health, community outreach, and community-driven research. What led to the focus of these specific things to try and navigate the landscape in front of us known as healthcare?
Well, one of the things that we recognized was that we've been talking about the same issues for the last 80, 90, 100 years, okay? And so we had to have a different kind of approach. We also knew that there were individuals and organizations that had been working on these issues, and so what we wanted to do was we wanted to take the time to what we call vet people, vet organizations, reach out to people, find out what they are really, really good at. I mean, because that's one of the things that I always ask people, like, what are you really, really good at? Because we can't do everything. And so it was important for us to find people who would stay in their lane and do what they were going to do, and that way we always felt like we could get to the finish line. But as I said a little bit earlier, one of the things that we knew early on was that the community has a lot of narrative. The community can tell you all day long like what's wrong with them, and you know. But when they go and they talk to officials, they don't want to hear that. They want data, right? So the thing that we wanted to do was we wanted to be in that space where we would be trusted by the community to hear them, and that we would be able to find the appropriate source or resource to give them the information they would need in order to be able to better tell their stories. So we're very clear about this, is that our goal is not to be number one. Our goal is to find people in the community that are actually doing the work and to support them as they do the work and provide them with the resources and information they need in order to make our community healthier.
Now, you all use the mobile medical unit as one of the tools or vehicles, so to speak, to really help you all do this work at HueMan. Can you talk to me about how that even came to be?
Well, interesting enough, HueMan, we were given a medical in 2011. We were given a medical mobile unit. We had a 37-foot medical mobile unit that was given to us by a health HMO. And we were long before there was community vans out there. We were out there, and so we've always known that we had to find different ways to provide services to the community. I left that organization, and what we did was we found partners who had medical mobile units, and we were still able to provide the services, but instead of us having the mobile unit, we had our partners work with it. And I think that's where Dr. Rhonda was talking about right now with the city of Minneapolis and the work that they're doing around this specific topic of Brixadi. So we just, like I said, we stay in our lane, you know, and we find people that are actually doing the work, and then we get along with them and we find out ways to support them as they do the work. So that's how we do it. We don't need to be out front. We just want we want healthy people. We want healthy communities. In fact, our one of the things that we talk about is healthy men, healthy families, healthy communities. That's what we are.
I think that's important to share with the community. You also shared on your website that you guys will be expanding your services surrounding the mobile medical unit, dental services, vaccinations, and opioid use disorders will be able to be addressed on the mobile medical unit. I think that is so important to hone in on, because I think despite what healthcare administration says, by not including our dental with our healthcare packages, with our insurance packages, so many things happen to us medically through our teeth and through our mouths. And when we neglect it for such a long time, whether it's a fear of the dentist's office or pain or creating a bill, it's so important. literally from the beginning of your life until you are in your twilight years to make sure that you are taking care of your oral health.
I'm glad you said that, because generally people don't identify that when we talk about health. And I happen to be a grassroots representative for a national oral health organization. And so I'm excited because you self-identified an issue that we want to help the community with. And so we know we will be coming back to you talking about oral health. But you're absolutely right. We have to have a much more holistic view of our total health. And that is one of the areas that we're definitely looking at and expanding. I will say this real quickly. We have a clinic over in St. Paul. Well, actually, we don't have it. It's called the PIP Clinic, Partisan Prevention Clinic, over in St. Paul at the Hallie Hugh Brown Center, which is one of the ways in which we do our outreach. And they actually will have dentists from the University of Minnesota there providing services in the community for people that don't have services or don't have coverage. So we do a lot of different kind of things. You took a look at our map. We try to be creative.
Yeah, and I'd like to circle back to two things. First is the dental health. A lot of times people don't understand that there are certain medications that affect their dental health. One very common one is Norvasc or amlodipine can affect the health of your gums. People who take medicines for either seizures or bipolar disorders, those medications can affect their gum and teeth. Also, to people who take medications for substance use disorder, the oral one, we're treating one thing, but there's been some what they call post-marketing surveillance where that has affected your teeth as well. And so even for a lot of times when I see people, when they come in very acutely to the pharmacy, they'll downplay an abscess or an infection. And what I have to tell people, we have this thing called inflammation of the heart, myocarditis. That infection can travel to your heart, and we've actually had documented cases where people, because they haven't had dental care, have literally died of this heart infection because that infection travels. So those things are just, again, sometimes underappreciated. I also wanted to circle back to the research component. Historically, research has been something very scary for people. We've heard numerous medical abuses, either in how we perceive the Henrietta Lack story, or even Tuskegee, or even there's a book by Harriet Washington that I have all students read in terms of medical apartheid. Research doesn't have to be scary. I think what's important is when you have people like myself or Clarence who are able to say, is it ethical? Who owns the data? And then how is this information being utilized? And so one example that I give people is understanding what you're signing. So there's one example I like to use is one in the pharmacy when you come in and people will tell you, you're signing saying that you're picking up a prescription. That is absolutely not what you're signing. You're signing a couple of things. You're signing either saying, one, I waive my right to speak to a pharmacist about this medication, or I am speaking to the pharmacist about this medication. The other thing a lot of times that you're signing is saying that I'm getting automatic refills, this is a 90-day supply, et cetera, et cetera. So always kind of understand what you're signing. The other thing is a lot of times when we sign in for our doctor's appointments, there's a box on there that says, you know, can I release this information to your insurance company? Can we, you know, treat you? But there's also a box on there that says, can your information or your chart information be used in research studies? And so a lot of times it's really important that we explain that down to, even when I do vaccinate people, tell them exactly what they're signing, that they understand the risk and benefits, that they've had all of these things, and people are kind of like, nobody's ever told me that. So it's really important to know what you're signing, but if you're not sure, just ask people who you see as trusted. But just understand that research is happening. My philosophy is not all research is great, but if we're ahead of it, and we own the data and we are able to actually train researchers that are reflective of the community, and then like myself who are vested in the community, we can get the cutting edge treatment, and sometimes treatment can be good and sometimes that treatment may not be for us. The other thing I'd like to add with that is really I've been encouraging providers to get away from race-based algorithms. We've removed a lot of race-based equations in terms of what we used to have for kidney function. That only changed in the last couple of years. So what was happening is for a person like my mom, this happened to her and she died of complications related to chronic kidney disease, is that those labs falsely elevated her kidney function. And then by the time it was time for a possible transplant or something else, it was too late. She had to go the dialysis route. So what we know now is we have what we call pharmacogenomics. That means like your body or your genes tell you or tell us how you process medicines. And a lot of that has absolutely nothing to do with race. So one example I use for myself, yes, I'm African American, my dad's part Greek, I have all of these different things, but I am a ultra rapid metabolizer of opioids. So that means if I go in to get a narcotic prescription, which I generally don't take, it takes a lot of it for it to work on me. So like the amount that I would need would probably be faster than, or the amount that I would need would be higher than my colleagues would need. So it's just making sure that we kind of stay on top of those things and not really fear it, embrace it.
I think one of the things I want to say is that I think you kind of get an idea about why we do what we do, is that there's so much that we want to and keep the community informed about. We have over 65 studies that we've done, or papers that we have done with community participation. So whatever we do with the community, if we talk about research, we make sure that the community is there from the beginning through the end, and then we make sure that their names are on the papers. You know what I mean? So it's not like we're taking credit for things. If someone from the community is contributing, their names go on the paper. We make sure that. I mean, that's just who we are.
I think that's not only ethical practice, but that's important to give credit where it's due, as we say
Correct.
in our community. Now, you guys talked a little bit, both separately, about the opioid crisis. And you all take care of and offer services around addiction at HueMan. There has been
We offer education.
Excuse me.
Yeah, we
Let
offer
me
education.
rephrase.
Yeah.
Education
Right.
around. So not treatment, but education for
education.
people, and then potential referrals for care.
Correct.
Am I correct in that?
Correct.
All right. I want to make sure I have that, so that people, one, are coming to you with the expectation of being able to be referred to someone else for services, but that they can be informed about
that's the whole
what's
problem.
going on. There is a spike across this country about opioid usage in teenagers all the way up. You all have a substance abuse training being offered to youth, which I think is so necessary. Within the last 1 to 2 years, I've read repeated stories of kids that have taken cars, are doing drugs in these cars, and then have left or dropped off friends in aimless areas that have had overdoses on opioids because they didn't know what to do. And when I looked at the website, I saw the graduates from 2023, and all of them looked like young people from my community, which made me happy to know that they're receiving training and then able to go out and into their communities and talk to their friends about something that I don't think enough adults talk about.
And interesting enough, we just did a training with youth in both English and Spanish, because we realized that we have a shifting population, and we just want to make sure that our kids are informed. And so that was recently, within the last couple of months, that we've been doing that.
I think it's wonderful that you guys are offering also a bilingual outreach component to this.
Yeah, and I would like to just credit Carmen and her network and how she's been able to do that. But one thing I like to go back is the opioid crisis. Historically, and I kind of graduated in what I would like to say is the OxyContin years, where it became a big thing. I can tell you when I first started practicing, I was practicing in North Minneapolis. People that looked like me or like yourself or like Clarence, we weren't getting the opioid prescriptions. We weren't getting the Percocet. We weren't getting the Oxycontin. People were coming from the suburbs to get these prescription filled. And so one of the things that I do when I'm in community, I would even say for me initially, I thought like for once when I first started, I was like, oh, this is not going to be a us problem. A lot of providers thought like, okay, because pain, we'll say it, is there are this disparities in pain management and the way it's viewed, and how even historically some people think that if you're of African descent that you can tolerate pain better and you don't need the pain medicine. So historically, if you looked at the data, Native American people, African American people were not getting these prescription pain medicines, but what happened is we started seeing heroin come back, and the heroin was very different. And so even when people were talking about the opioid crisis, they were like, well, it's not, we don't have to think about that. And what we started seeing is heroin and fentanyl. And so when I'm in community, I don't call it an opioid. I call it what it is. I kind of look and say, like, this is heroin. I do know not too far from where we're recording right now, you can get heroin $2 or $3 a bag. It's very accessible. It's very readily available. And then things were laced with fentanyl, which was very potent. And so what we're even seeing now is this, we talk about polypharmaceuticals. From a prescription standpoint, there's no just regular heroin or no regular marijuana or no regular meth. You're seeing these products being combined in ways that they have historically never been combined before. And so that's what is challenging. It's rather unfortunate. And so even I think about with cannabis now being legal, people think legal means safe. We need to think about it. Alcohol is legal, but is it technically safe? And so it's just really important to know what you're consuming, where you're consuming, and even utilizing things where you can test for the presence of certain substances. So I just thought it was important to kind of say, if we say opioid, people are like, oh, not us. Fentanyl and heroin, I've seen young people try their first marijuana for the first time and not make it. And just so that people know it's not just happening in community. As a pharmacist and as part of my role, I've traveled to national conventions, and it was kind of just heartbreaking for me to see when we were in a room with a bunch of pharmacists, where pharmacists have actually even lost their kids to substance use disorders, or just have known somebody affected by it. So it's not a us-them issue, it's an everybody issue.
I appreciate the distinction. I think it is important to call a thing, because I think sometimes people shy away from terminology because it feels less taboo. If I'm dealing with this and I got it from a pharmacy, or if I got it from a friend who she doesn't even drink, but she gave me a pain pill at a party, and now.
And one of the things that I like about HueMan and our partners is that we believe in being authentic, telling the truth. Like I said a little bit earlier, is that we work very hard to earn the right to speak about hard topics. And the work that's happening in our community, it's hard. We're struggling with the issues and diseases, the same issues, same studies over the last 50 years. And at some point, we have to get to a place where we make informed decisions. And so that's why we do what we do. That's why we find what we call treasures in our community. Those are people that are actually doing the work, and we just say to them, like, hey, how can we support you as you do the work? Because it takes all of us to make this happen. And so many times we are segmented. We have myths, we have those kinds of things, and so we have to be patient and understanding and intentional in terms of our work. And so we even appreciate having the opportunity to be here, you know, because, you know, it's our community. If it happens for me, it's going to happen to you. You know what I mean? So we need to not run away from that.
That's very true. Now, I just want to switch gears just a little bit before I let you both go and talk about what have you all heard from the community. We're seeing the landscape of healthcare change on a civic level. Bills are being rolled back under the cover of night with this administration, and people are scared to get any type of mental health or medical treatment because they don't want to create another bill, or they're scared about so many other things that are existing from a societal standpoint at this time. Clarence, what are you hearing from the community as you're out in the public talking with people about not only what the work of HueMan is, but what's really on their hearts concerning their health and their family health?
Well, one of the things, and I think you said it very, very eloquently, is that one of the things that we're dealing with really is a lot of false information, false news. I mean, you know, something comes out of Washington one day and then they take it back the next day. I mean, it's really stressful. People are concerned, but what HueMan does is that there are things that are out of our control, but what we try to do is we try to leverage relationships so that when people or when the community needs something, we can provide them an appropriate answer. You know, like I tell people, I'm a fatherhood doula, right? So you know what a doula is, right? Okay. But I always tell people I work from the waist up. I don't do that stuff on the bottom, okay? But what I know though is that you have to find your lane. And that's really what we're interested in doing, is find out what is it that we can do. We have people like Dr. Rhonda. We have other people that are strategists. I mean, they know what they're doing. We have to work with them to help our people know what they can do and what information is necessary.
Yeah, I hear a lot of different things, and most of it is people in this state have no idea the wealth of services and things that are provided. Minnesota has it's called a preferred drug list, so they always say PDL, of a list that Minnesota medical assistance programs will pay for. By far, it's the most expansive in the country. People are able to get access to health care here that they would never be able to get anywhere in the country. I think part of it is that sometimes when you have this wealth of stuff being thrown at you, you don't know how to navigate it. So one thing is like too, if you go to the hospital, what people don't know is the hospital, they have those financial advisors. It may seem very intrusive, but I've helped people negotiate their bills when they didn't have insurance, where they end up having to pay, you know, a couple $100,000 on a, you know, $100,000 bill. There are resources here. It also used to be illegal for pharmacists to tell you what the cost of your medication was or is, and even understanding that we have like prescription discount cards. So now, like for example, for people who are insured commercially, which is through their employer, they might have a mental health medication like generic Vyvanse or Adderall. When I run it through their insurance, it might be $300 or $400. Well, now legally, I'm able to tell them if I run it through this discount card, it's $34. So again, it's, I think, really finding trusted partners or trusted people where you can go and get information, and then really saying, okay, like, one, I don't want this shared, or two, can you point me to resources to help you navigate these things? But again, we're very, very fortunate, and I would be remiss if I didn't talk about the city of Minneapolis and their Brixati project and how it's funded. To their credit, and to Suzanne Young and Commissioner Damone Chaplin and Deputy Commissioner Heidi Ritchie, they went out in community and said, what do you feel about this opioid settlement dollars? And historically, what they were doing was just giving people Narcan. As a pharmacist and as a clinician, well, what I know is I give somebody Narcan, without treatment, they're actually more likely to die of an overdose because of the withdrawal is so strong. And so this is a novel project where the city has found ways to use those settlement dollars to actually pay for treatment for people to get inducted, and kind of, either use patient assistance programs or their insurance to continue to do that. And when I do have that opportunity, I like to say and tell people that you can get that induction really at Fairview University Hospital on Riverside. Walk into the ER, and if you are a candidate for that, they will give you that medication there. So we're very fortunate here. I do think we need to understand how to use those resources judiciously, or even use them, because sometimes if they're not being utilized, then they will no longer be funded. So I think it's just speak up, find partners that you can connect with, and I think we're very fortunate in that I know I have a Rolodex, and I'm saying Rolodex, it's really now my cell phone, of people that I can just point people to, and don't feel like I have to own those relationships. I think that was the thing that really had me gravitate towards HueMan, is I don't gatekeep relationships. If I pass you off to somebody else, you don't have to tell me what's going on. And but I do care about community members in their experience. So if the experience is positive or negative, like, come back and let me know, so maybe that's not for you. But that's kind of like what I'm thinking, and I feel again very fortunate to be here today, and then just being fortunate to work with a bunch of collaborators who continue to push the envelope and say, like, just because we did it this way 5 years ago, 2 years ago, it may not be the best way. And so that's one of the things that really excites me about this work.
Clarence, let me know where we can find you all if we want to stay connected to the work that's going on at HueMan.
The best way to do us is to go to www.humanpartnershipalliance.org. Again, that's www.humanpartnershipalliance.org. Or you can reach out to me, 612-759-2170. I'm more than happy to talk to people. My phone is open, 612-759-2170. So, and I appreciate you allowing us to have this opportunity to talk about this, and we look forward to working with the community. So if people are looking at us and they say, like, they'd like to find out more, go to the website. But I always tell people, probe us, ask us questions, vet us, make sure that we're doing what we're saying we're doing. But we've been around for 25 years plus, and so we believe that we have earned the right or deserve the right to be at least considered for things around health. So thank you very much.
Absolutely. Dr. Rhonda, it has been a pleasure. Clarence, it has been a pleasure. I am grateful to amplify the good work that you guys are doing out in the community. And it is our hope that someone has found something that was said or shared here enlightening or informative, so that they can take those little pieces and take them back to their communities and connect people to good work and good resources.
And I'm happy to come back on. Like, a lot of what we talked about today is so many topics, and people are like, oh, my mind is spinning. But if you see that, you'll get to know me, and my mind is always thinking all over the place. But I know sometimes as we're in this uncertain time, there might be more issues that people in the audience are looking for. You can certainly connect with me via the mechanisms that Clarence has. I also am on LinkedIn. I try to share a lot of health information on that. And again, not just connect people locally, but connect people nationally. So when I have that privilege, I do try to utilize that as well.
Yeah.
I appreciate that. And that is actually a gem to be able to offer the community at large, because we know that all of our viewers are not in our backyard here in the Twin Cities. So hopefully you all will connect with Dr. Rhonda and let her help you as you try to navigate your healthcare journey going forward. Or if you need some resources on what that may look like, be sure to connect with both of these amazing people. Unfortunately, that is all the time that we have for this episode of Community Connections. As always, I am your host, Anna Orr. This has been Community Connections, airing right here on OROMIA11. I look forward to connecting again with you soon.